Okay, Dr. Myers, all yours.
Okay, so welcome. Today's webinar is called Psychogenic Non-Epileptic Seizures, What a Psychologist Needs to Know. I am Lorna Myers, the Director of the PNES Treatment Program at the Northeast Regional Epilepsy Group. And although the title says what a psychologist needs to know, the objective of the webinar is, in fact, to provide a brief introduction to PNES for all mental health professionals, including psychologists, but also psychiatrists and social workers. So a brief overview of what we're going to talk about today, beginning with an introduction to PNES. We're going to go over some definitions and facts, how it's diagnosed, and what the comorbid psychiatric conditions associated to PNES are. We'll also talk about why psychologists are so important in the treatment of patients with PNES, and what do we know about the utility of existing treatments that can be employed. We'll discuss general recommendations for psychologists or mental health professionals who are planning on treating a patient diagnosed with PNES. And at the end, we'll go over some resources for professionals who are working with this disorder, as well as for patients that are living with this disorder. So starting out with just three very basic definitions. We're going to define seizures, epilepsy, and PNES. Seizures are defined as an involuntary behavioral change. It can involve movements of body parts, alterations of consciousness, loss of certain functions, for example, speech or vision. Seizures can be generalized, affecting the entire body, or partial, affecting only part of the body. And seizures can be seen in both epilepsy and in PNES. The definition of epilepsy is that this is a diagnosis that is given to a person after they have had more than one seizure, and the seizures are unprovoked, meaning that there was not a drug or alcohol that was consumed that provoked that seizure. And the seizure that occurs during epilepsy is associated with an abnormal electrical activity in the brain. PNES, seizures in PNES can appear very much like an epileptic seizure. Behaviorally, they resemble an epileptic seizure and can be very hard to discriminate. But they do not demonstrate epileptiform activity during recording of brain waves when an EEG is being used. So a definition of PNES could be, and there are a number of them, but we can start by using, this is an episodic behavioral event that resembles epileptic seizures, but is not associated with abnormal epileptiform electrical discharges of the brain. PNES is associated with underlying psychological stressors, and there's often a history of psychological trauma. PNES is not a single entity, but rather a diagnosis that is given due to the symptoms of seizures, but which is associated with multiple psychiatric comorbidities. And the seizures are conceived of as symptoms of an underlying psychological condition. The reason this is underlined is because this is clearly a psychological condition, and this is why we are discussing this today as mental health professionals. As per DSM-5, PNES is classified as a conversion disorder or a functional neurological symptoms disorder. Functional referring to some form of abnormal central nervous system functioning of unknown etiology. They are now, at this time, typically called either PNES or FNSD. And this definition, or this diagnosis, requires a few criteria. A would be that there is one or more symptoms of altered voluntary motor or sensory functions. B, clinical findings. Symptoms are incompatible with medical or mental disorder. C, symptom of deficit is not better explained by another medical or mental disorder. And D, these symptoms are causing significant distress or impairment in social, occupational, or other important areas of life. and they are typically considered F44.5, which would be this conversion disorder, or FNSD, with attacks or seizures. There are a number of risk factors in those who have PNES. I'm going to list just a few. The one that stands out quite a bit is that there is often a history of traumatic or adverse life experiences, including significant health events, as well as physical, sexual, emotional abuse, major losses, deaths, and so forth. There's a history of psychiatric disorders that often includes depression, anxiety, post-traumatic stress disorder, and personality disorders. And there is often a history of medically unexplained symptoms. PNES, from a historical perspective, has been around for a very long time. These seizures, psychogenic seizures, are the most common paroxysmal events that are misdiagnosed as epilepsy. They tend to fall in an intersection between neurology and psychiatry, psychology, which complicates smooth transitions to treatment. PNES has been recognized historically for a long time. There have been some somewhat unusual theories and explanations as to what is causing these seizures, including some of the more colorful ones, wandering uterus, where it is suspected that seizures might be resolved by becoming sexually active or having children, and that in some way, perhaps through sexual repression, these seizures have come about. And there have also at times been explanations of demonic possession. Although this is now almost completely in history, I have encountered patients in the 20th and 21st century who are still sometimes being told by their family or by people who know them that what they're having could possibly be explained by one of these theories. PNES has been around for a very long time, and if any of us have taken Psychology 101 courses and we ever read anything about Charcot or Breuer or Freud, we've read about hysteria and the use of hypnosis, dissociation, conversion of psychic symptoms into physical symptoms, the famous case of Anna O, and the importance of psychological trauma, which began to be understood way back then. This is the history of PNES with a lady here who is has apparently fainted and is being examined by this group of doctors. Although this happened historically, it continues to happen. The only difference is that now most of these patients are not seen in regular medical settings, but rather in epilepsy centers. Just a few more facts. What is the correct name for PNES? We are calling it PNES throughout this presentation, but there are some terms that continue to be used and that are either deemed to be offensive or have been abandoned by most health professionals, but they still linger from time to time. The current acceptable term is psychogenic non-epileptic seizures, PNES, or as in England, non-epileptic attack disorder, NEAD, N-E-A-D. Terms that have or should be abandoned and that tend to be rejected quite vehemently by patients is pseudo-seizures, hysteroepilepsy, or hysteria. In particular, pseudo-seizures continues to be used by a number of professionals, and there is a growing movement that is a grassroots movement that is opposed to this term because it has connotations that refer to faking or to somehow presenting things consciously and for a secondary gain. So it is recommended that if you are working with these patients, you should not be using this term anymore, and you should be using a much more descriptive and accurate term of PNES or NEAT. A few more facts about PNES. PNES occurs most frequently between the ages of 20 to 40 years, but it can happen that someone much younger or someone older than that develops PNES for the first time. It is much more common in women with a 3-to-1 ratio. The average time that elapses between the first seizure and a definitive diagnosis is 7.2 years. Often these patients are diagnosed with epilepsy and are treated with anti-epileptic medications. These medications are unnecessary and are also not helpful. There are a number of patients who've also had experiences in emergency rooms where they are taken by emergency personnel. They're intubated. They are treated with medications that are not appropriate for PNES. So this is a very worrying average time between first seizure and the definitive diagnosis of PNES. And it would be really a very, very important goal to shorten this time. Up to 20 to 30% of patients evaluated on an inpatient epilepsy monitoring unit may be diagnosed as having PNES. So there are a large number of these patients that eventually end up in the funnel of the epilepsy monitoring units in hospitals. Estimates of PNES prevalence ranges from 2 to 33 out of every 100,000 persons. This is from a publication that Benvedis and Hauser put out in 2000. And approximately 5 to 10% are dually diagnosed with PNES and epilepsy. And those in particular, those patients who have a dual diagnosis of PNES and epilepsy are very tricky to diagnose and require some very careful examination and then understanding of which seizures are non-epileptic and which ones are epileptic. So how is PNES diagnosed? And we're not going to talk about this too much, but this is the important first step, usually that precedes the entry of the mental health professional, but is incredibly important to have had the diagnosis confirmed, and this is how it is at this point being confirmed. PNES can have a multitude of presentations. There can be paralysis, violent thrashing, slurred speech, stuttering, blinking, odd eye movements, alteration of consciousness, etc., and can very much look like an epileptic seizure. So a simple observation, visual observation of the seizure, although there are some key signs that neurologists and epileptologists may use if they suspect that there is PNES. The gold standard for a diagnosis of PNES is something called a video EEG, during which all the typical events are recorded. And this says all because there could be different types of events, and you want to be sure that you've captured all of the typical events and that they were all non-epileptic, and that you're not dealing with someone who has dual diagnosis of epilepsy and PNES. You want to be sure that during this test there are no associated epileptiform discharges that are noted before, during, or after the event. And you want also to collect a history and semiology that should be consistent with PNES. So there's something called the National Association of Epilepsy Centers, and they have guidelines for referrals for seizure disorders. And the association states that delayed or denied referral may be detrimental to the patient's health, safety, and quality of life. The guidelines are that if seizures have not been brought under control after 3 months of care by a primary care provider, family physician, or pediatrician, further neurologic intervention by a neurologist or an epilepsy center is appropriate. So this is after 3 months. A general practitioner has been seeing the patient. There is no improvement. So then the referral is made to the next level of specialist. If seizures have not been brought under control after 12 months while being treated by a general neurologist, a referral to a specialized epilepsy center epileptologist should be made. If these guidelines were followed, it's much more likely that we would cut down on that 7.2 years average time between first seizure and definitive diagnosis that we talked about earlier. And I've listed a link down here that is from the American Epilepsy Society. This is a link to find an epilepsy doctor or epilepsy center based on zip codes. This is a useful piece of information. If you are seeing a patient who is having seizures and is not responding, it would not be inappropriate to discuss the possibility of needing a second opinion, and this would be a good place to start to look for an epilepsy specialist. So how is PNES diagnosed? We've got a picture here of what a video EEG machine would be like. The patient is hooked up to an EEG through leads on the scalp. And these leads, actually I'll show you something else. The patient is hooked up in this way with leads placed on the scalp. And then this right here, which are these squiggly lines, are the brain waves that are being picked up by those leads. And this is a camera that is filming the patient while the study is ongoing. And this is where you would see what is being filmed. So the epilepsy specialist will be looking at the behavior that the patient is exhibiting as well as the brain waves and seeing if those coincide, if those are consistent with an epileptic seizure or not. It's a very, very complex piece of machinery to be able to diagnose someone with PNES. It's only in the last 4 or 5 decades that this equipment has been around, and probably less than that for video EEG. And this is what has really moved the diagnosis of PNES forward in a dramatic way. This is a different kind of machinery that is also used for the diagnosis of epilepsy and PNES. This is called an ambulatory video EEG. So again, you have a camera that is with the patient, and this briefcase contains all of this, which is also the machinery for the EEG, and the leads are placed in the office, and then the test goes on for several days in a natural setting that the patient lives in. So in addition to all of that machinery and all of those tests that are being run, while still an inpatient, it is recommended that those patients with clinical features that are consistent with PNES should be evaluated by a mental health provider. This clinician, during the interview, will determine whether there are typical risk factors, emotional triggers to seizures, significant psychiatric comorbidities, and past attempts at solutions, as well as other pieces of information that might be useful. So the interview is really very important at this time, because whatever is obtained through that interview is also combined with all the other results that are being obtained while in the hospital. But if it is not possible to perform a psychological assessment during the hospital diagnostic phase, the psychological assessment should be performed as soon as possible as an outpatient, and then therapy should begin as soon as possible as well. Now, PNES is much more than seizures, although seizures are the very dramatic way in which it presents. The seizures tend to overshadow other things. But frequently, patients with PNES have one or more of the following: depression, anxiety, trauma, PTSD, pain syndromes, dissociative disorders, personality disorders. So we're just going to go very quickly over some of the numbers that have been reported, that have been published on comorbid psych conditions in PNES. There are reports of unipolar or bipolar depression in anywhere from 21 to 78% of patients with PNES. Approximately 50% of patients with PNES also carry a diagnosis of anxiety disorder. Up to 25% are reported to have made a suicide attempt. 75 or more percent of patients with PNES have a history of trauma. And depending on the study, anywhere from 22 to 100% carry a diagnosis of PTSD. Pain syndromes have been reported in anywhere from 22 to 89%. Dissociative disorders anywhere from 22 to 91%. Personality disorders anywhere from 10 to 86%, with predominantly borderline and obsessive-compulsive personality disorders. They often suffer from medically unexplained symptoms and US. And family characteristics in patients with PNES also tend to present unique features. Families do tend to have more difficulty with communication, affect, and general functioning. There have been a number of studies that have looked at this. Families of origin of patients with PNES tend to have more health problems, a greater tendency to somatize, and can be more critical and distressed even than families of patients with epilepsy. And there tends to be a family psychiatric history that is uncovered during interview. Approximately 30% of patients with PNES fulfill a criteria for alexithymia. Emotional processing is a serious issue. Many patients can be classified into one of two subgroups, undermodulators or overmodulators. Undermodulators tend to have very high emotional reactivity, low tolerance to excitement, difficulty controlling emotions, poor quality of life, and considerable psychiatric comorbidities such as depression, anxiety, and borderline personality disorder. There tend to be issues with coping with stress, with a tendency to be more emotional or avoidant in stress management rather than task-oriented. In contrast, overmodulators tend to exhibit emotional avoidance. They're excessively controlled in their behaviors. Somatization tendencies, psychiatric comorbidities are less obvious. And often the patient will present very much focused on the symptoms of the seizures and is not as interested in speaking about any stress or any issues that are psychological. Now, these patients can be resistant to the psychogenic diagnosis, but with clear explanations in patients, they too do understand and benefit from treatment. It just requires a different approach. So we're going to shift over now to what treatments are available. And we're going to talk about just 4 different kinds of treatments, although my suspicion is that for the most part, there are so many variations in those persons who are diagnosed with PNES that one particular treatment may be appropriate for one person and not a good match for someone else. May also depend on what time in the life of the disorder we are meeting the patient, and these are the 4 treatments that we are going to be talking about are the ones that have been reported and empirically studied. But there may be other treatment approaches that are quite useful and that are simply not mentioned because this is a very brief review of what has been published so far. So definitely psychotherapy is the indicated mode of treatment once the diagnosis of PNES has been made. And there is empirical validation and reports of utility of the following treatment approaches, including psychodynamic therapy, mindfulness-based therapy, cognitive behavioral therapy, which includes prolonged exposure for dually diagnosed PNES and PTSD patients, and psychoeducational group interventions. I've put a star next to cognitive behavioral therapy because this is the modality that has been most examined and is at this point showing the strongest results. So let's start talking about psychodynamic therapy. And anyone who's listening to this may have a preference or a particular approach that they use. This is only meant to be a very brief introduction, a very brief description of these 4 different treatment modalities, as well as mentioning 1 or 2 articles that have recently been published. So from the psychodynamic therapy perspective, psychogenic symptoms are typically seen as produced by internal processes resulting from traumatic memories, often from childhood, that are maintained at an unconscious level through dissociative, conversion, and somatic defense mechanisms. The goal of psychodynamic therapy is to bring unconscious material to the surface to promote change through insight. There have been 2 important studies in recent years that have looked at the effects of psychodynamic therapy on PNES. Oliveira and her co-authors examined 37 patients who were treated with weekly sessions of psychodynamic treatment for 12 months. What they found was that 29.7% stopped having psychogenic seizures completely at the end of treatment, and 51.4% had a decline in seizure frequency. The decline was not defined, so there's no precise number for what exactly this meant and what percentage this represented. There's also a need for follow-up data on the maintenance of these improvements. That was not provided in the paper and is often not provided in many papers that have looked at effectiveness of therapy for patients with PNES. And Mayer et al. Represents a particular study that did look at follow-up of patients, and it's one of the few. In this paper, what was described was an augmented psychodynamic interpersonal therapy of 2 hours semi-structured initial interview and up to 19 50-minute weekly or biweekly sessions. So by the end of this treatment protocol, 47 of the 66 patients completed follow-up questionnaires. A total of 66 patients completed the treatment, but only 47 of 66 completed the follow-up questionnaires at a median of 42 months. And this went anywhere from 12 months to 61 months. Of those 47 patients, 12, a total of 25.5%, reported that they were event-free, and 19, a little bit over 40%, had experienced a greater than 50% reduction in event frequency at the follow-up period compared to baseline. These are 2 important studies that have been recently published and that are supportive of psychodynamic therapy as effective for PNES. Mindfulness-based treatments for PNES are also just recently starting to be spoken about and researched. Mindfulness involves being aware, moment to moment, of subjective conscious experiences. The regular practice of meditative practices improve attention and emotional regulation, as well as body awareness. All of these are key targets in a disorder such as PNES, so it makes perfect sense from a theoretical perspective that this would be a good approach to use with patients with this diagnosis. Particularly patients with PNES often present with alexithymia and the difficulties that we talked about before with over-modulation of emotions, and they tend to avoid distressing thought content and so forth. So mindfulness comes in and really targets those aspects quite beautifully. With this treatment modality, experiential avoidance is challenged while personal values are delineated, and that provides patients with healthier, consciously chosen behavioral pathways. that can replace the seizures. And there is a researcher, a neuropsychiatrist, Gaston Baslet, who's at Brigham and Women's Hospital in Boston, who has been really spearheading research in this area. A recent article that he published in 2014 reported that of a total of 6 adult females who were enrolled in a 12-session mindfulness protocol, by session 12, all had a reduction in event frequency, and 3 of 6 had stopped having episodes completely. There were also improvements in depression and anxiety. The treatment components are psychoeducation and goal setting, stress management training, mindfulness training, emotion recognition, acceptance, and behavioral regulation. So these are the targets for this particular treatment. Move on now to cognitive behavioral treatments for PNES. CBT operates on current maladaptive thoughts, behaviors, and feelings with the aim of producing healthy changes. This approach proposes that core beliefs of oneself, others, and the future can be modified through certain interventions, and dysfunctional thoughts and behaviors related to conversion symptoms can be challenged and changed. The CBT is the psychotherapeutic approach that has been reported to have the highest level of efficacy evidence at this time for PNES. And there are a number of studies that are very good and very thorough. We will just talk about 2 of them. Goldstein and et al. From 2010 published a randomized controlled pilot study in which a group received treatment as usual, TAU, and the other group received CBT. The treatment components were treatment engagement initially, reinforcement of independence, distraction, relaxation, and refocusing techniques when an episode was imminent, graded exposure to avoided situations, cognitive restructuring, and relapse prevention. The CBT group experienced a significant reduction in monthly episodes. Frequency for treatment as usual group was at a median of 6.75 monthly episodes, while those who received CBT plus treatment as usual were experiencing 2 monthly events. However, at 6 months follow-up, the statistically significant difference was lost, although improvements were maintained. Another study that we'll talk about is a study by Kurt LaFrance, 2014. And in this study, he conducted a multi-center pilot randomized study that produced Class 1 data. A total of 34 patients were enrolled into 1 of 4 treatment arms. Those arms were 1, flexible dose sertraline hydrochloride only, 2, cognitive behavioral informed psychotherapy, 3, CBT informed psychotherapy with sertraline, and 4, treatment as usual. Both the CBT IP alone and the CBT IP with sertraline showed the most improvements. The CBT only group showed a 51.4% reduction in event frequency and a significant improvement on several secondary measures of depression, anxiety, quality of life, and global functioning. The CBT plus sertraline arm showed significant reduction of a 59.3% in monthly events and significant improvement on secondary measures of global functioning. Now, there is a need for follow-up data on maintenance of the improvement that was reported in this study. I am not aware of any follow-up data that has been published at this point. And we'll just very quickly go over what the CBT IP that we were mentioning in the previous slide is about. There are a total of 12 sessions, and they are described here very briefly. Session 1 is making the decision to begin taking control. A very important issue with PNES is control, loss of control during seizures. And during this session, there is a focus on the importance and the active decision of taking control. Second session, getting support. Third session, deciding about your drug therapy, whether it's necessary or not. Fourth session, learning to observe your triggers, which is a very important piece as well for PNES, becoming much more aware of what occurred before the seizure, what might have triggered it. Initially, that may not be obvious to the patient, but with work and attention and by keeping a log, this is possible to achieve. Session 5, channeling negative emotions into productive outlets. Session 6, relaxation training. Session 7, identifying your pre-seizure aura, simply meaning what are the signs, physical signs that the patient may have prior to the full-blown seizure. It may be a headache, it may be tunnel vision, may be heart palpitations, change in breathing, and so forth. Working with the patient so that they identify what this aura is. Session 8, dealing with external life stresses. Session 9, dealing with internal issues and conflicts. Session 10, enhancing personal wellness, including exercise and diet and so forth. Session 11, other symptoms associated with seizures. And session 12 is taking control, an ongoing process. And for a number of patients, treatment can finish at this point, but there is another substantial number of patients who may need ongoing treatment or who may need to have booster sessions from time to time or fine-tuning sessions from time to time. And I do often discuss this with patients that we may complete a course of treatment and that there may still be a need for either continued treatment or for a return to treatment at some point in the future. I always find that it's best to have that discussion. Now, another form of CBT treatment for PNES is specifically for those patients that have PNES and PTSD. And we said before in a previous slide that approximately, depending on the study, anywhere from 22% to 100% have PTSD. In my experience, it's usually lower than 100%, but typically anywhere from 25 to 40-something% will fulfill criteria for PTSD. So these particular patients have a dual diagnosis of two very, very troubling conditions. PNES, which in itself is a very disabling condition, and PTSD. Prolonged exposure therapy, PE, is a very effective treatment for the treatment of post-traumatic stress disorder. It was developed by Edna Foa. The core components of exposure therapy are to replace the avoidance behaviors with exposure and confrontation. And it's basically made up of two different kinds of exposure: imaginal exposure, which involves revisiting the traumatic memory, repeated recounting of it aloud, and processing the experience of memory recollection. And in vivo exposure, which involves the repeated confrontation with situations and objects that have been associated to the trauma and that cause the stress, but that are not inherently dangerous. CBT treatment for PNES PTSD, in particular prolonged exposure, acts on 4 different areas. The avoidance symptoms, it acts on it because the memory and other life aspects are not being avoided, but rather they are being confronted. It acts on intrusive symptoms because the patient learns to recollect the memory and associated thoughts voluntarily instead of being intruded on. It acts on hypervigilance because the patient learns that many of the dangerous situations are in fact safe, and because intrusive symptoms come down. And it acts on negative thoughts and mood because there's a sense of achievement and regained confidence. In particular with PTSD and PNES, PE, in my view, is not only acting on those 4 aspects that we talked about: negative thoughts and mood, intrusive symptoms, hypervigilance, and avoidance, it is also acting on the seizures, which represent an avoidance 2.0 type of mechanism. Now, in 2015, there's a study that we have just presented and will be presenting at the American Epilepsy Society. 7 adults were enrolled. They were dually diagnosed with PNES and PTSD. They completed 12 to 15 weeks of PE, and the results showed that there was a significant reduction of depressive symptoms, post-traumatic symptoms, and seizure frequency. Follow-up at anywhere from 2 to 27 months, depending on the patient, revealed that all patients had maintained improvements regarding seizure frequency, except for one patient who had suffered a bit of a reversal, had not gone back to where she had been initially, but was having an increase of seizures compared to when she completed treatment. 5 of these 7 were either working or enrolled in school. This is a very important finding because there is such a high incidence of disability and chronicity in this patient population. And the fact that these patients were resuming activities was very important. So PE with patients with PNES in this particular study was administered according to the manual with some modifications that included specifics of PNES and to address overengagement. And the treatment components are the same as one would find in the actual manual. The only differences are that the session in which common reactions to trauma are discussed includes PNES as a potential common reaction as well. During the trauma interview, detailed descriptions of seizures are also obtained. Seizure logs also become part of the homework, and breathing and grounding techniques can be used during the episodes themselves to recover control. Let's move on now to the 4th type of treatment that we're going to discuss today, psychoeducational groups for PNES. Way back in 2004, Zaroff et al. Conducted a psychoeducational group with 7 patients for a duration of 10 sessions. The topics at that point covered education about PNES, anxiety, depression, trauma, anger, and assertiveness, healthy behaviors such as diet, sleep, and exercise, PTSD and dissociative symptoms, and emotion-based coping strategies. PTSD and dissociative symptoms and emotion-based coping strategies decreased at the end of these 10 sessions. This is really a first attempt at any type of formal treatment in a group setting, and is now often cited as a more historical type of publication. What was found, though, is that through these 10 sessions, there was an improvement, like I said, in PTSD and dissociative symptoms, and there was a decrease in this emotion-based coping strategy. There was also a trend towards a improved quality of life, and event frequency did not change significantly, although there were only 7 patients, and 3 of those 6 were seizure-free at outset. A much more recent psychoeducational group study is from 2014. Chen et al. Compared an intervention group consisting of 3 monthly psychoeducational meetings and a routine seizure clinic follow-up control group, so treatment as usual. The interventions that they had, that they used were lectures on PNES and safety and universality of the condition. 2, how physical symptoms can arise from underlying emotional causes. And 3, empowering patients to take control using distress tolerance techniques, relaxation exercises, and scheduling time for naps. I'm not quite sure why that was included, although I'm suspecting that's part of a wellness intervention. Patients were prospectively followed at 3 and 6 months. And although there was no significant change in event frequency or intensity, means that they were still having the same number of seizures or the same intensity of seizures, there was a significant improvement on the scale of work and social adjustment, and a trend towards decreased emergency department visits or hospitalizations in the intervention group. This last fact is a very important one, because the cost of this disorder is astronomical, with emergency department visits or hospital stays when patients have either not been correctly diagnosed yet, or when the seizures are still persisting even after a diagnosis. So now we're going to shift. We've been over definitions of PNES and facts about PNES and the 4 types of treatments that have been reported and published about. And now we're going to shift to just some recommendations, common sense and practical recommendations for psychologists. So this is based on my experience of working with patients with PNES now for over 10 years. And it is simply my perspective or my recommendations, not to be written in stone, but they have been useful for me. And I expect that they might be useful for someone else who is just starting to work with patients with PNES. In particular, despite the fact that there are these treatments and that there are psychologists who are quite competent in the administration of these treatments, the problem continues being that these seizures, when they present, are very dramatic. They're very off-putting. They can be scary. They can just be flat out unusual, and will often either give the mental health professional the sense that this is outside of their scope of practice, or that the diagnosis needs to be re-verified, or that this is actually a neurological condition and not a psychological condition, and so forth. So this is why we started out talking about the importance of the diagnosis, and that the diagnosis should really be made by an epilepsy center, an epileptologist, with this gold standard that we talked about with the video EEG. But when a patient does come with a diagnosis that's been confirmed with one video EEG, or often even more than one video EEG, it is important that the mental health professional understand what that diagnosis meant, how it was confirmed, and to then work in the direction of treating the psychological issues, whether there is a seizure or not in the office. So some of the practical advice that I can give is that at the outset of the treatment, it's important to obtain a description of the typical seizures and what their frequency is. I'm going to want to know, does the patient have an aura? Does the patient feel something in their body, either palpitations or a headache, or hear a sound or something that tells them before they have a full-blown seizure? So I'm going to want to know about that, because that is something that I'm going to want them to share with me if they are having a particular aura. I want to know how the seizures start. What do they look like? They can look in all kinds of presentations. So I want to know if someone starts out by falling over, or if someone starts out by simply being quiet and being just sort of shut down. What are the characteristics? Does the patient fall? Do they vocalize? Do they thrash? Do they shake? Do they self-harm? For example, scratching or banging the head. Do they move around? Do they bite? Do they vomit? Which happens rarely, but it does happen in some cases. Is hearing, speech, or writing retained during the episode? This is very important, because if hearing is retained, this allows the therapist to be able to continue speaking with the patient and guiding them during the episode. If writing is retained, then this will be a way of communicating, even if the patient cannot speak. And I also want to know the duration. Some seizures last a minute, some seizures last hours. So I'm going to want to know what we're walking into. Is there something that the patient finds helpful during the episode? For example, is it helpful to be able to focus in on something, or to hear someone speaking to them. And how long until the patient fully recovers? Fully recovers means that they can actually go home. I'm always also going to make sure right at the beginning that I have an understanding with the patient that I, or you, the therapist, will be perhaps touching them during the episode. So you're going to come to an agreement as to what part of the body is safe to touch, and if there is a part of the body that cannot be touched. So for example, if the patient was perhaps bound by the wrists during the traumatic events that occurred, then wrists may be off limits. Is it okay to squeeze an arm or a shoulder, which is usually my preferred place of touching a patient? So just touching the arm or touching the shoulder or stroking the hand. And if the patient falls, I also want to make sure that it's understood that I may need to hold the patient to avoid injury or hold their head to avoid injury, or maybe need to lift their head to place a pillow under it. So we have this discussion where we go through all of the possibilities, understanding what that patient's particular seizures are like and what we may need to do in the event of a seizure. Not necessarily expecting that there will be a seizure, but in the event of a seizure, so that we know all of the different things that might happen. Another recommendation for a psychologist would be that you do want to ensure that the patient is safe from injuries, and this may sometimes require making necessary modifications to the office during the session. Questions to ask yourself: does the session need to be conducted on a carpeted floor, so off the chair and onto the floor? Is there wooden or hard furniture that needs to be moved out of the way? Do you have a pillow that you can perhaps place under the patient's head? And if the patient, for example, scratches themselves, should they use mittens? These are just some examples. I typically begin therapy by teaching a breathing retraining exercise, and I make sure that it's well practiced and learned. Breathing retraining exercises are going to be a key part of therapy and of interventions during an actual seizure. I typically speak to the patient during the episode. It is very rare that the patient is fully unconscious, and typically there is an alteration of consciousness, but most patients can hear what is being said. I use this as a grounding technique where I'm reminding the patient that they are in my office. I'm reminding them who I am. I'm reminding them what we're doing, what we were talking about, or what we were involved in at that time before the seizure occurred. I may repeat to the person that we are talking about memories and that we are now in a very different time than when that memory occurred. Depending on how the episode is presenting, I will often, after a minute or two, be able to suggest to the patient that the episode is near its end, and we'll begin to focus on breathing. And then, once the episode has resolved, typically we will work on processing what happened as soon as it ends. So I think it's very important to know that it's not necessary to stop a session just because of an episode. If the patient can continue, the session should continue. It's important to assess if the patient can continue talking about that particular distressing topic that might have preceded the seizure, or if you should move on to processing and discussing other important topics. A number of patients have complained to me that sessions are often cut short as soon as they have a seizure. While it is very, very possible that the patient will recover and can continue, and in fact, you get a lot of good work done after the seizure. And you also get the chance to show the patient that that particular avoidance mechanism occurred, that they were able to control it, come out of it, and that they can continue to work. an important recommendation for a psychologist or any mental health professional would be to not leave the patient alone or allow them to leave the office until they are recovered. What I will often do is, if I am at all concerned that a seizure might occur and that it'll be hard for the patient to leave the office, I will ask them to have someone accompany them to the appointment and wait in the waiting room. If the patient came by himself or herself, we'll make sure that we have an emergency contact number from the outset that we can call. And the patient will wait until the companion can come. If there's an exam room, the patient can sometimes rest there or remain in a waiting room. And I'll sometimes ask my office staff to monitor if I'm with another patient. This last point is a very important one. Unless the patient has hurt herself or himself during the episode, for example, fell and hit her head or has some sort of other injury, or if the episode is notably different than any other typical episode, or if the patient is not responsive, I typically avoid calling 911. 911 often results in an ambulance being taken to the hospital. There can be a whole series of medical procedures that are performed on the patient that are not necessary. So unless there is something that is different or that concerns me, or there has been an injury, the attempt to work through the seizure and to then help the patient through the recovery process without calling 911 or an ambulance should be the way to go. You know, most seizures are dissociative in nature, so some of the things that I have found helpful are to use grounding techniques, either small bags of ice or a frozen orange that can be held, paddleboard with a little ball. I had a particular patient who was a hula hooper, and so as we were doing the session, she would use a hula hoop to maintain herself concentrated on doing two different things, transferring an object from one hand to another. All of these can be helpful during discussion of intense topics. If you're conducting PE in particular, it can be helpful to do imaginal exposure retelling of the memory very quickly, or using writing, or using technology. There are some patients who become mute during the episode but are still conscious, and there are some apps that can be used to retell the taped memory, and in that way exposure can continue. So we've finished with most of the presentation. We're just going to go over some of the basic resources that are available. And there are some resources that are directly for professionals, and then there are others that are for patients. We did mention before that in order to help your patient find an epileptologist or an epilepsy center in the U.S., this is a link where you can go and look up based on zip codes. This is the American Epilepsy Society link for a Find a Doctor. Sometimes patients have some very simple questions about, frequently asked questions about PNES. This is a link for frequently asked questions. PNES treatment referral sites. This is another link for a total of 15 states are represented in these referral sites here in the U.S. I would love for there to be a total of 50 states represented. So if someone who is listening to this webinar is a mental health professional who is interested in working with PNES, who has experience working with PNES, and who would like to be listed, you should contact me. I'm going to provide my email at the end of this presentation. I usually do contact and speak with the people who are listed on these on this page. just to have a better understanding of what sort of work you are doing with PNES and what your approach is and so forth. And also so that we can make a connection. Some of the, there are a number of professional resources. I'm just going to mention three. There is a review paper that is hot off the presses. It's not even hot off the presses yet. It's still in press. This is something that we worked on with a group of researchers and clinicians who specialize in PNES. And it is now in press in the journal Psychosomatics. It is called Psychogenic Non-Epileptic Seizures, an updated primer. Even though I was a participant in this, I do recommend it. And I find that the work that the whole group did was very good in presenting a overview of PNES and a whole series of different aspects of PNES, as well as treatments and challenges and so forth, and in a summarized format. There are two books that I would recommend for professionals. There's the Therapist Guide, CBT-Informed Therapy by Kurt LaFrance and his co-author. It's called Treating Non-Epileptic Seizures, Therapist Guide. It's from the Treatments That Work series, and it's available on Amazon and so forth. And the second book that I would recommend is the Gates and Rowan's Non-Epileptic Seizures, 3rd edition. Again, an excellent book that does a fantastic job of covering all aspects of PNES from a professional perspective. Patient resources. In the last few years, there has been a flurry of books that have come out. They are all fantastic in their own sense. The oldest one is the second one that's listed here, Lowering the Shield, Overcoming Psychogenic Non-Epileptic Seizures. It's by John Doherty, and it was, he is the husband of a person who lives with PNES, and he wrote the first and really excellent book on what his perspective was as the spouse of someone who has PNES, the struggles that they faced, and he has a lot of recommendations on how to navigate the health system and so forth. Psychogenic Non-Epileptic Seizures, a Guide, is a book that I published in 2014. Again, it's a book that is written for patients and loved ones. It has ended up also being read by a number of therapists as well. It goes over what PNES is, different treatment modalities, provides exercises, although it is not meant to replace formal therapy. But it is an introduction, definitely, to what the condition is, and is meant to educate the patient on what resources are out there. More recent books that have just come out, The Color of Seizures, Living with PNES by Kate Taylor and Jeffrey Underwood. Kate Taylor is a person who lives with PNES. In Our Own Words, Stories of Those Living with, Learning from, and Overcoming the Challenges of PNES, came out this year as well. My co-author is Mary Marderos. It was her brainchild to produce this book. It is a compilation of 19 testimonials of people living with PNES from across the U.S. and from across different countries. And the most recent book that I've seen is called View from the Floor, Psychogenic Non-Epileptic Seizures, A Patient's Perspective by Kate Berger, another beautifully written book that would be ideal to recommend for patients. Additional resources for patients, continuing education scholarships for adults diagnosed with PNES are offered through the Epilepsy Free Foundation. Although the name of the foundation is Epilepsy Free, it does provide scholarships for patients who are diagnosed with PNES as well. There are also PNES awareness garments and charms in exchange for donations that are available on Epilepsy Free. And I run a Facebook page called Psychological Non-Epileptic Seizures that is for patients. Basically, it is a venue to announce news stories or different events that are occurring with PNES. There are a number of PNES Facebook pages, so I'm not going to list all of them because I would probably forget one or two. So I'm going to stop here and just say thank you very much for having attended this webinar, and I hope that I've piqued your interest in this very interesting group of patients, and that this information is going to contribute to the work that you'll be doing with these patients in the near future. I'm providing my email, and I provide my address as well, and I'm always very open to speaking with therapists or with different providers about questions that may have arisen about patients that are being treated that have PNES or that are suspected to have PNES. So definitely, if there is a question, shoot me an email. I'd say that you know, this is a very challenging yet very, very enriching group of patients, and I hope that some of what we've talked about today will prove helpful in the work that you do. So thank you very much.